I don't know actually if I'll enlighten your way or I'll make it more difficult. We know actually that 40 to 60% of DVT patients will develop some sort of post-thrombotic syndrome, and usually this happens within 2 years. And iliofemoral DVT patients had the most morbidity to have a severe post-thrombotic syndrome. And we know as well that retrieving such a thrombus in either an artery or vein is much easier than treating such a vein. When you get this thrombus out of the vein or an artery, it's better than treating this collagen and fibrous tissue later on. We know as well that this patient might present to you later on in their life with different aspects of post-thrombotic syndrome and venous ulcers, and this has a negative impact on mobility, functional capacity, work attendance, and other aspects of quality of life in different age groups, not to mention the cost as well. We know as well that the Villalta scoring scale, which ranges from 0 to 33, was the main tool that was used in most of randomized controlled trials to assess post-thrombotic syndrome. And when we go through the main 3 randomized controlled trials that we will discuss today, the 𝗘𝗴𝘆𝗽, the 𝗓TRACT, and the 𝗘𝗴𝘆 trial, we have to make just a quick comparison between them. All of them were randomized controlled trial, and the 𝗘𝗴𝘆 trial was done in Norway, and it was the first published, followed by the 𝗓TRACT that was done in 56 clinical centers in the States, and the 𝗘𝗴𝘆 in 15 centers in Netherlands. And these are the centers used to collect the patients, not to perform the procedures. The age was quite similar, with a bit older age group in the 𝗘𝗴𝘆 trial, and the onset was between 2 to 3 weeks from the onset of symptoms or the diagnosis of the acute DVT. All of these patients had iliofemoral DVT, but the 𝗓TRACT trial actually took patients in consideration with 𝗔𝗆𝗆𝗃𝗃 DVT as well. So all the studies compared the conventional treatment in the form of anticoagulation, compression, and early mobilization versus either catheter-directed thrombolysis in the 𝗘𝗴𝘆 trial or pharmacomechanical thrombolysis in the 𝗓TRACT trial, or the ultrasound-accelerated catheter-directed ECOS thrombolysis catheter in the 𝗘𝗴𝘆 trial. And the outcomes were mainly the post-thrombotic syndrome, and in all studies this was mainly assessed by the Villalta score. The 𝗓TRACT and the 𝗘𝗴𝘆 actually commented on pain, swelling, quality of life as well. I won't go through this busy slide because you can read and you know all of you the studies, but just I want to emphasize that actually the thrombotic agent or thrombolytic agent that was used in the 𝗘𝗴𝘆 and 𝗓TRACT was the 𝗓-𝗏, while it was urokinase in the 𝗘𝗴𝘆 trial, and there was a duration up to 4 days in the 𝗘𝗴𝘆 and the 𝗘𝗴𝘆 trial in comparison to 30 hours in the 𝗓TRACT trial. And the patients were recruited in the 𝗘𝗴𝘆 from 2006-2009, in the 𝗓TRACT from 2009 till December 2014, and the 𝗘𝗴𝘆 from May 10 to September 17. Number of patients were variable, and the 𝗓TRACT actually is the biggest trial, but they included 𝗔𝗆𝗆𝗃𝗃𝗃, and this was almost half of the patients, and iliofemoral half of the patients. And the outcome, surprisingly, to most of the people who were involved in the study, it didn't show actually superiority of the thrombolysis except in the 𝗘𝗴𝘆 trial. If you will take the primary endpoint, which was the post-thrombotic syndrome assessed by Villalta score, while actually in the 𝗓TRACT and the 𝗘𝗴𝘆 trial, there was no significant difference between both groups. But there was significant difference in all the studies as regards the major bleeding. The only study that showed absolute risk reduction was the 𝗘𝗴𝘆 trial in the form of 14.4%, and this increased to 28% reduction in 5 years, and number to treat to get 1 free post-thrombotic syndrome was 7 in 2 years, and 3 in 5 years. So does additional thrombolysis prevent post-thrombotic syndrome or just increase the risk of bleeding? In history, actually, there was randomized controlled trials done to compare anticoagulation versus thrombectomy, and showed superiority of surgical thrombectomy, and this was maintained in 5 and 10 years. And surprising as well, if you review literature, the first published randomized controlled trial comparing anticoagulation to thrombolysis was done in Egypt by Dr. 𝗔𝗆𝗆 and 𝗪𝗏, and included small number of patients, but it showed patency and normal valve function in the thrombolysis, catheter-directed thrombolysis group, better than anticoagulation, but they didn't assess any clinical aspects. So when you go to critique in these randomized controlled trials, it's better to differentiate between facts and fake conclusions. But we can tell the 𝗘𝗴𝘆 trial actually showed that in 2 years and 5 years, there is a preference to do a thrombolysis, catheter-directed thrombolysis, in comparison to anticoagulation. And it showed us as well after 5 years that post-thrombotic syndrome is still progressing in patients who had only anticoagulation more than in patients who had thrombolysis. But the 𝗘𝗴𝘆 didn't answer all the questions. The 𝗘𝗴𝘆 didn't show any difference in the post-thrombotic syndrome in both groups, and 26% of patients were discontinued from the study because of inability to lysis the thrombus burden. The ATTRACT is the only trial that included 𝗔𝗶𝗆, as we have mentioned, and they assess the patient clinically and with SEEP classification, venous clinical severity score, quality of life, and 𝗔𝗶𝗆. But Dr. Komurota himself said many times in many occasions that it was a poor choice to adopt post-thrombotic syndrome assessed by Villalta score as a primary endpoint. And the reason for that, when they revised the results, they found actually the Villalta score didn't improve a lot, but the venous clinical severity score improved in the patients who received pharmacomechanical thrombolysis. And if we will go further to discuss the pain and swelling, there was significant difference in favor of the pharmacomechanical thrombolysis. As well, if we go to the severe and moderate post-thrombotic syndrome, not all post-thrombotic syndrome, there was an advantage to use the pharmacological thrombolysis in these patients in the ATTRACT trial. So, despite that the 𝗘𝗴𝘆 is the only trial that achieved the primary endpoint, there was an achievement in the ATTRACT if they adopted the venous clinical severity score, and there was improvement in the swelling and the quality of life and pain for these patients. When you go to the subgroup analysis of the ATTRACT trial, it showed actually the age was one of the factors that improved the outcome. So if you treat younger patients, it's better. If you treat patients who are more liable to have major risk to develop further DVT in the future, they will have better outcome. And patients who are presented with more severe disease at the beginning, as regards swelling and pain, will get better outcome if they get thrombolysis or either pharmacological or mechanopharmacological. So where do we stand? Are all iliofemoral DVT are the same? No, they are not. We can see many patients who have iliofemoral DVT and they have very minimal symptoms, and we see patients who have iliofemoral DVT and they have phlegmasia. So there are a lot that we have to learn and to study as regards the pathology and the collateral development in the acute status. We treat a patient, not a scan, so we cannot build up our decision for thrombolysis solely on the site of the DVT. More symptomatic patients will benefit more from thrombolysis. If you have IVUS, we have to use it. The key success should be the removal of as much as we can from the thrombus burden in the iliofemoral segment. To assess if we have achieved this goal, venogram is not always enough. If we have to stent a patient, we have to use a dedicated stent. Femoropopliteal DVT for conventional treatment only, anticoagulation, compression therapy, and please, early mobilization. No one is confined patient to beds in DVT, in acute DVT, anywhere in the world. So how would I use thrombolysis? Who would I use thrombolysis for? Young, mobile, active patients with severe initial symptoms and signs of DVT, and or high risk of future DVT who has iliofemoral DVT proven clinically and radiologically to be an acute event started less than 21 days. How I would treat them? Cross-sectional image pre-procedure is important to know the anatomy and the congenital anomalies. Consider distal axis. Many authors now are suggesting posterior tibial venous axis better than popliteal axis. Consider pharmacomechanical more than pharmacological. IVUS if available, and stent if indicated. Thank you very much.